Welcome everyone. We're off to a slightly late start this afternoon, just going on for everybody. So thank you everyone and welcome to MRFTT STI Echo. My name is Dr. Boyce. I'm your facilitator this afternoon. To my right, the next getting in camera is Dr. Musa, and presenting our didactic today is clinical psychologist Belinda White, and she'll be presenting on somatic disorders and other diagnoses in HIV. So let me just pull that up quickly. Quickly being a relative to. All right, and we're good to go, Belinda. You can start whenever.
Okay, thank you. Good afternoon, everyone. My name is Belinda White. I'm clinical psychologist here at Medical Research Foundation. Today, I'll be presenting on HIV and somatic symptoms and related disorders. Before I begin, I'd like to offer an acknowledgement of the program funding and give a reminder that this presentation is not intended to replace medical advice. So, learning objectives. So the first learning objective we have today would be to define somatic symptoms and related disorders according to the Diagnostic and Statistical Manual, version 5. Apply the biopsychosocial model to the development of somatic symptoms and related disorders. To discuss most common somatic symptoms and related disorders found at MRF, and to apply the biopsychosocial model to a case presented here at MRF. Next slide. So, according to the Diagnostic and Statistical Manual, the main characteristic of the disorders captured in this category is the prominent presence of a somatic symptom that can be associated with significant distress and impairment. Now, this significant distress and impairment is evidenced in an individual's daily life, and each domain of their life may be compromised due to the presence of this somatic symptom and the distress that it may cause. The rationale for giving this diagnosis is very important because there are several components to it. The first component is the presence of distressing somatic symptoms, and that should be in addition to abnormal thoughts, feelings, and behaviors in response to these symptoms. Therefore, the affective, cognitive, and behavioral factors presented are critical to the diagnosis. And so, the diagnosis is not given on the grounds of there being a somatic symptom present or in the absence of a medical explanation. There must be a clinical look at the individual's response and reaction to the symptom that they are experiencing. I believe it is criteria B in somatic symptom disorder, which is the main disorder within the category. It focuses on an individual's thoughts, feelings, and behaviors related to the symptom. And so it's like an equation. There has to be the somatic symptom, but then there also has to be the reaction and the behaviors that accompany that somatic symptom to equate a somatic symptom disorder or related disorder diagnosis being given. Next slide. Sorry. So here's a list of all of the diagnoses and disorders that can be accounted for in this category. Of course, as I just said, somatic symptom disorder is a major diagnosis within this category, followed by illness-related anxiety, conversion disorder, psychological factors affecting other medical conditions, factitious disorder, other specified somatic symptoms and related disorders, unspecified somatic symptom and related disorders. Now, the key feature in conversion disorder and other specified somatic symptom and related disorders is they can be medically explained. For example, pseudocyesis that falls within item 6, which is other specified somatic symptom and related disorders, because there is a trademark symptom, which is that of pregnancy, that can be validated or not with medical examination. And so for somatic symptom disorder and illness-related anxiety and the others, there is no real medical explanation for these symptoms that persons may be experiencing, and the absence of that medical explanation does not warrant a diagnosis being given. However, for conversion disorder or an other specified disorder like pseudocyesis, that medical explanation holds great weight and can definitely influence a diagnosis being given. Next slide. So here we have the biopsychosocial model. Where the biopsychosocial model and somatic symptoms are related disorders. So we're all familiar with this approach, the biopsychosocial approach. And this stems from the biomedical model, which failed to include many factors that can influence the formation and development of an illness, as well as the management of an illness. And so the biopsychosocial model is a more all-encompassing model and considers all factors. And so, of course, this model includes the several contributing factors that are active in someone developing a somatic symptom disorder, like biological factors, for example, would be their genetics. For example, their increased sensitivity to pain or an impairment like a neuroendocrinal impairment. And also social, which I find very interesting. So studies show that children who are socialized or in their socialization, they learn that physical symptoms get attention as opposed to psychological ones. And so when someone presents with psychological distress, they are not attended to, they are not cared for. But when you have a physical ailment, you do receive the attention you desire. And so that socialization and learning as a child is an active part in someone developing somatic symptoms within their later life. Other factors that are social could be traumatic experiences, like experiencing violence or abuse at an early age during adolescence as well. And then there are the cultural and social norms, where psychological suffering is stigmatized and physical suffering is more accepted, and one may receive help for physical suffering as opposed to psychological suffering. And so we also have the psychological factors to consider, which would be coping skills. For example, someone who develops a somatic symptom or a related disorder, they usually have maladaptive coping skills, and they do need quite a bit of support in that area. Next slide. So somatic symptoms and related disorders, that's MRF. Comorbidity between somatic symptoms and related disorders and the following have been identified as MRF. So the two that are most common would be depression and anxiety. So depression, of course, is a mood disorder, and this is actually the most commonly given psychological diagnosis since I have been here. It's a significant number of clients that I have seen have received a diagnosis of depression, whether it be a depressive episode, persistent depressive disorder, major depression and peripartum onset. So, of course, depression has many sub-diagnoses under it. However, it is the most prevalent diagnosis given. And when someone is experiencing a depressive episode, the likelihood of them experiencing a somatic symptom is also increased. So, for example, patients may have a complaint of joint pain or fatigue, muscle pain. They may also be experiencing insomnia, and this is caused by rumination about. So, rumination is that overplaying of thoughts constantly in your mind about their health, right? So it's like a vicious cycle. Someone is depressed and they develop somatic symptoms, and these somatic symptoms exacerbate the depressive symptoms that were there before, and more somatic symptoms may develop, and so it continues. The next is anxiety. This presents as illness-related anxiety. In DSM-4, it was termed as hypochondriasis. So clients describe a persistent worry about having or acquiring another serious, undiagnosed medical illness, or about their HIV status worsening despite adhering to treatment. So I'm sure many of the doctors at MRF have had patients with this anxiousness about their health and worrying about the tablets causing them to die. Even if they take the tablets, they're going to die anyway. And so it's also a pretty common occurrence. However, I've not given as many diagnoses. Many persons don't necessarily meet the criteria for the diagnosis of an illness-related anxiety disorder, despite having anxiety. So I did have a patient a couple of months ago. No, not yet, Dr. Boyce. This is an anxiety patient. So she presented to the clinic and was referred to me, a woman in her early 50s. And her complaints were, of course, somatic. And they were along the lines of she had the desire to sneeze and she could not sneeze. She had the desire to belch and she could not belch. She may not have used the washroom for one day, and so that would have caused her a lot of concern. So this client definitely met the criteria for somatic symptom, and the related disorder is illness-related anxiety, because these symptoms that she may be experiencing or that she was experiencing were not catastrophic ones. However, her response to them were of a catastrophic nature. So she was in significant psychological distress by the time she got to me. She was very tearful about these symptoms that she was having. I'm very concerned about her health, very, very worried about what would happen to her. And so we have the cognitive, emotional, and behavioral aspects of her response to consider. And this is why she comfortably met that criteria for the diagnosis of illness-related anxiety. Her cognitive response was one of catastrophizing these symptoms that she was experiencing. The emotion would have been an intense emotional reaction evidenced by crying and increased anxiety. And her behavior was actually going to numerous medical facilities for assistance. So the last time I saw her, she explained to me that she was having a difficult time with her throat. Her throat was very dry. And she was having a hard time dealing with this persistent dry throat. And so she said that she drank a lot of water and her throat was still feeling dry. And so she went to the emergency room. And while at the emergency room, the doctors may have recognized that it was anxiety related and gave her referral to a mental health facility. However, she was dissatisfied, as most patients are when they have somatic symptoms. They find themselves in a position where they are dissatisfied with the medical support they receive. So they go to another agency to get a second opinion and to be evaluated again. And so they continue going to many different agencies, and what may happen is their anxiety may become even more exaggerated because they keep hearing, well, there's nothing wrong with you, but yet their physical symptoms persist. Or, as in this lady's case, she received an opinion from numerous physicians and medications from numerous physicians, which was quite confusing for her. And so she found it difficult as to what to do, because she also had an earache, an ear infection. And so she got medication from the hospital, she got medication from here, she got medication from a private doctor, and then at the end of it all, she was terribly confused as to what she should do and which medication she should take. And so this behavior is really typical of someone who has somatic symptoms or a related disorder. Is their dissatisfaction with medical attendance that they get as a primary care healthcare setting, because that's where they show up most. They are not necessarily seen very frequently in mental health settings because, of course, somatic symptoms present like physical ailments, and so they go to a primary healthcare setting to receive care for that. And so they experience significant dissatisfaction, and they tend to go to many different agencies to get a second, third, fourth, fifth opinion, which seems to exacerbate the negative or unpleasant emotional experiences that they are having. So the next slide is another case that I encountered with Dr. Boyce at MRF. Next slide, Dr. Boyce. So this client is a 45-year-old, sorry, that's the wrong age, she's 35, a 35-year-old heterosexual female, and her diagnosis was pseudocyesis. So this falls within the other specified somatic symptom and related disorder category, which I mentioned at the beginning of the presentation. So presenting symptoms were swollen stomach, enlarged breast, nausea, weight gain, mood swings, belief that she was approximately 4 months pregnant despite the lack of medical evidence. And the interventions done at that point was a urine pregnancy test and ultrasounds. So by the time I met her, she actually came to me as a referral related to IPV, intimate partner violence. And in talking to her, I recognized that she presented all of these symptoms. I mean, she satisfied the criteria for the visual representation of a woman who is pregnant. She actually looked about 6 months pregnant to me. And in talking to her, she explained that she was not in a clinic, but she had all of these symptoms, and she had a sonogram, an ultrasound, sorry, but she was dissatisfied with the performance of the sonographer, because she felt like the person administering the ultrasound did not do a good job, they did not take their time, and so that is why they weren't able to provide evidence of the pregnancy. And so her belief of her pregnancy persisted despite that ultrasound. And she also indicated to me that she had taken numerous pregnancy tests. I think she purchased a couple, and she also received a pregnancy test at the clinic on the day she saw me, and that test was negative. However, in talking to her after taking that test, pregnancy continued to persist. And her rationale was she knew a woman that had present symptoms of being pregnant. However, none of the tests identify that they are pregnant, and she also saw it on TV, etc. So she had reasons to support her belief of her being pregnant despite the medical evidence that was presented to her. And so she met the criteria for pseudocyesis because, of course, we have the medical evidence, right? But then we also have her reaction set, which is the cognition of her believing that she is pregnant and her justifying it through knowing persons who've had similar experiences and seeing this thing on television. Her emotional responses, she became very emotionally aroused when she spoke of the pregnancy, and she also often became very irritable with the persons that she lived with, including her partner. They have a very volatile relationship. And her behavior is, as I said, the first time I met her, all of her behaviors indicated that she was pregnant. And she even had to like rush off to the bathroom because, she couldn't hold her urine for long. She had increased eating habits because of the pregnancy. But then I also noticed there was some apprehension in attending the medical settings to which she was referred. So after I saw her the first time, she received a referral to go to get a second ultrasound. And it was quite some time before she actually went to get it done. And I noted that that apprehension as a behavior, as to her being somewhat avoidant of having further medical evidence that does not align with what she believes to be true. Next slide. So this slide applies the biopsychosocial model to this case that I just mentioned of the 35-year-old female presenting with pseudocyesis. So like I said, there are several factors that contribute to the development and management of any disorder, particularly mental health disorders. So the biological factors that she has were the history of challenges with her reproductive organs. She had an operation in the early 2000s to remove a cyst. And the studies show that persons who have abnormalities within their hypothalamic pituitary ovarian axis are commonly they commonly present with pseudocyesis, as well as neuroendocrinal changes, which is I believe responsible for hormone production and changes in their hormones, and of course impairments in both the HBO axis and neuroendocrinal changes. Sorry, were also are evidence because of the presence of ovarian cyst. I'm sorry, I'm not too familiar with these medical terms. I'm doing my best. And so these are the biological factors that were present for her. But then we also have the biological factor of her possibly having a substance dependency, and she uses cannabis quite frequently, an average of 5 times per day with her partner. Psychological factors. She was given a psych diagnosis during her childhood of depression. She reported that she was seen as a psychiatrist during her early childhood, as she was ward of the state. She was placed in St. Jude's home for some time. She has a history of abuse during her childhood and her adulthood, which included incest, and she also has poor coping skills. Now, this is very interesting to me. I've had quite a number of clients who say to me, I had a nervous breakdown, and a nervous breakdown is not a psych disorder and not a diagnosis. And so it's very interesting. Of course, she could not tell me more because she did not go to St. Anne's, to which she was referred by the doctor who she saw at that time. So she does have a very complex psych history, but we know that a diagnosis of depression was given to her in childhood. And if depression in childhood can manifest in later adult years into personality disorder, or just as we're seeing here, somatic symptom disorder or related disorder. And she also has a history of high-risk behaviors, which include years of sex work. The social factors would be limited education, unemployment. She and her partner are government supported, limited social support, and an abusive romantic relationship. And she has a history of previously unstable relationships. And so this client sort of meets all of the criteria for an individual who has to have certain prerequisites to develop pseudocyesis. This client seems to have most, if not all of them. So presenting the factors that precipitated her presenting problem of being pregnant was the abuse that existed in her relationship and the pressure that she experienced from her partner and her partner's family to get pregnant. And of course, she had challenges with that because of her reproductive issues, right? And the cysts that she had, etc. And so there's the abuse that she was receiving from her partner, the pressure, the social pressure from the community and persons that she interacted with frequently. But then these biological factors that were not working with her. And so in addition to her poor coping skills and her history of abuse and her psych diagnosis during childhood, all of those things come together and present themselves in her interpreting these symptoms of her cyst as symptoms of pregnancy and firmly believing that they are pregnant. And in my opinion, in my estimation, this was a response to the trauma and abuse she was experiencing. And so it was much easier to explain to her partner that all of the symptoms that she had is a result of pregnancy and not a cyst, because he so desperately wanted his child, and it was that child and having a family conversation was the source of a lot of abuse and friction within their relationship. So we can move on to the next slide, which is my final slide, which is a review. So firstly, somatic symptom and related disorders is a category of mental illness captured in the DSM-5. Next is there are several biological, psychological, and social factors that may contribute to the development of a somatic symptom and related disorder. Next is specific focus should be paid to the individual's affective, cognitive, and behavioral response to the symptom, as this is critical to the overall clinical picture. I did not mention earlier, but this aspect is so important because it could actually lead to identifying a delusional disorder or a thought disorder. And so if an individual, of course, somatic symptom disorders they have a very high comorbidity rate, and so they could be comorbid with many other illnesses, including a thought disorder, right? And so if you have significant medical evidence that is present, and then there's intervention supporting the fact that these are somatic symptoms and not an actual medical issue, and it persists, then we can consider a thought disorder, for example, a delusional disorder, right? And I was actually considering that for the 35-year-old female as well, because she firmly held on to that belief. However, the last time I saw her, she seemed to be accepting that she was not pregnant, and we had a very open conversation about it, not taking away from the fact that she is mentally ill. However, I ruled out that delusional disorder. Next is the diagnosis of a somatic symptom or related disorder should not be made on the sole premise of there being a lack of a medical explanation for the symptom. And finally, as MRF, somatic symptoms have been most commonly identified in clients who have a comorbid mood disorder, specifically depression or anxiety. So that's it for my presentation. Thank you very much for listening. If you have any questions or thoughts to share, please feel free to do so.
Thank you, Belinda. Excellent presentation, and particularly interesting in terms of how in-depth we went to that biopsychosocial model. I think a lot of us as clinicians sometimes have experienced, for example, even with this pseudosciences example, of rather bruising encounters between clinical staff and patients, where someone comes and, as you say, presenting to clinicians, not to mental health experts, thinking they're pregnant, pregnancy is negative, and someone will tell them, but you're mad, you're pregnant, you're faking. And I think it underlines the need for sensitivity and how you manage patients like this, because they're not faking it. They really do have this belief that something is going on with them physically. And in order to move them forward, you have to be careful and delicate in how you handle those issues. Thank you very much. Any comments or questions?
Yes, definitely.
Maybe just to say that even though patients have somatic symptoms and diagnosis, sometimes it can be, let me use the word, very dangerous, because sometimes when patients are deemed to have a somatic symptom, details are not taken, and sometimes they sincerely have a completely different problem. I say this because I remember when I was a fifth-year medical student, there was a 16-year-old girl who had this bloated belly, and everybody in the wards believed that because she had been coming to the wards almost every 2 weeks, that it was somatic illness. And one night I went to the wards and this girl was crying and the belly was bloated, and I wheeled her to the X-ray department, took her to a surgical registrar, and I was told that is just somatic, there's no problem. I went and reported to my registrar, and he told me, no, we know her, there's no problem. And the following day she died. And one other lady who was related to a number of doctors who had endocarditis, bacterial endocarditis. And she would be that sometimes when we went to the ward, she would cover her head and start crying. And it was assumed she didn't have any other problems. And the day before she died, the senior doctor said, well, I found her pretending. And for the sake of completion, just in case of any doubt, I sent her to ICU. And the same day I met her brother downstairs, and she died the same day. Thirdly, pseudoscience is the few I've seen are some of the most difficult patients to manage. I remember one lady also when we were students, and she came so many times that finally she ended up in the maternity ward, and she went back home and convinced the husband that she had made twins, and the doctors and the nurses couldn't allow her to carry the children home. So she came with the husband to pick the children. And of course, there were no babies anywhere. And it can be very tough, because I know there's one of our patients who has been having her periods every month, but she's been pregnant for the last 1 year. And there's nothing you're going to tell her to convince her that she's not pregnant. And her reason is that the other ultrasound she had, the nurses told her that there was a cyst in the uterus. And now she's stuck on that as to what was this uterus cyst, if it's not a pregnancy. And convincing her that she's getting her periods every month and she's not pregnant, and ultrasounds are not demonstrating any gestational sac, and pregnancy tests are also negative, but she still believes she's pregnant. It's just great what the mind can do sometimes, because as you said, they get high bellies and they're maternity dresses, and it can be very, very difficult.
Yeah. That patient, Dr. Musa, was actually referred to me as well, but I never got the opportunity to meet with her. And I think in a case like that, where they do meet the criteria for pseudosciasis, I think it's important to remember the possibility of comorbidity. And so someone, for example, with a thought disorder, presenting them with facts, like a delusional disorder, presenting them with facts that does not work, that intervention is met with a lot of opposition, and they may get very violent, irate, like, how dare you tell me I am not pregnant? Because I absolutely am. And so there has to be, I think, once the practitioner recognizes, okay, this person has somatic symptoms, yes, and they satisfy the criteria for that, but then they also are open to comorbid mental issues that may be present as well, that would require other intervention, right? And so the intervention taken for a thought disorder is different from a somatic disorder, because for somatic, you can treat the person with cognitive behavioral therapy, and you can probably provide them with some medication, but it is definitely different from the medication someone with a thought disorder like schizophrenia or delusional disorder may receive, right? And so recognizing that both disorders exist in this individual, and they require, I hope you all are hearing me clearly.
Yes, yeah.
There's a lot of noise. So in recognizing that both disorders can exist at the same time in this individual, and determining what is the best intervention that may be most suitable for this individual. What are these symptoms that are most prominent in their presentation? Even if the somatic symptoms are there, for her, it may be the delusions, that these firmly held beliefs that are not shaken regardless, because of course, someone can't be pregnant for 1 year, right? And so just having general knowledge of pregnancy, that in and of itself should be something interesting to say, well, maybe I'm not pregnant, right? But in her, that shows a lack of insight. And so that lack of insight is maybe indicative of something else to be considered.
All right. Thanks so much for that. So we'll just move on. If there are other questions or comments, move on to the case this afternoon. So again, quote unquote, quickly moving on.